Thanks, Ron. It's my privilege to introduce a new colleague here from UW, Janelle Sobecki. Dr. Sobecki is an assistant professor in OBGYN, specializing in gynecologic oncology. She's a career mentored research scientist in a program called BIRCH, which advances research careers in women's health. She trained at Northwestern before her fellowship here at UW, and her recent work has focused on bone loss following GYN cancer diagnosis and treatment, and that's what she's going to share with us this evening. Dr. Sobecki.
Thanks so much, and thanks for having me. Pleasure to meet you all virtually today. Like Neil mentioned, today we're going to talk a bit about bone loss and gynecologic malignancy, which you will learn is a little bit of an understudied area. We're going to go through some of the current data, and then I'll share with you some of the recent research efforts by my team. I do not have any conflicts of interest to report. So a little bit of background. So what you guys may be familiar with is that there is a higher prevalence of bone loss in patients with cancer in general. A lot of the data regarding this has been done in cohorts of patients with typically breast and prostate cancer, where a lot of this data is coming from. But we do know that those with cancer do have a higher prevalence compared to those without of bone loss. This is for, secondary to a handful of things. There are direct effects of cancer on bone cells and bony metastases, and there are a lot of secondary effects of cancer-directed therapies. So we know that adjuvant therapies and primary therapies like chemotherapy, radiation, hormonal suppression are all increasing bone loss in our patients with cancer. And, in addition to that, these patients often also have the presence of other common risk factors that we typically associate with bone loss. And oftentimes, cancer in many people is because, age is a huge risk factor. And so with age also comes an increased prevalence of bone loss. In terms of gynecologic cancer, there are a lot of risk factors for these patients. So one thing that is a bit different than other cohorts of patients with cancer is that most patients with gynecologic cancer are undergoing bilateral oophorectomy or ovarian removal, which is pretty much ubiquitous in our group, with the exception of just a very, very few amount of patients in which we're able to do a contralateral ovarian sparing surgery. Most patients also then receive adjuvant therapy. So this can be chemotherapy, radiation therapy. We do have, a cohort of patients who, whether in the upfront or recurrent setting, can also receive hormonal therapies. Many of our patients undergo treatment prior to natural menopause. There's a decent percentage of patients we take care of who are diagnosed, before the age of 52, which we kind of commonly think of as the average age of menopause. Many of our patients have long-term survival. So when you've got women who are undergoing oophorectomy, chemotherapy, sometimes chemotherapy and radiation therapy, all premenopausally and have excellent prognosis, there's a lot of time going by in which, bone loss can end up becoming an important issue for them. As I alluded to, there's very little data in this cohort. Gynecologic cancer has not been a cancer that has been well studied in the realm of bone health. And so there is a bit of data, but not as much as you would maybe think there were. And it's definitely an area that needs a bit of robust prospective study. There's also no standardized methods for bone health screening in the cancer world. We're going to go through this a bit, but there's a lot of recommendations from a lot of different societies, and there's certainly nothing specific for gynecologic cancer itself. So the current survivorship landscape. So what we typically think about in survivorship is, bone health is certainly on the list of things that patients, will discuss with their provider at surveillance visits. But there's no real guidelines, particularly in the gynecologic cancer world, as to when this is talked about, how often people are being screened. And I would say, at least in our clinics here at Wisconsin and some of my colleagues across the country, nobody has a standard way of doing this if they're doing it at all. Nearly all of the guidelines have been based on data in non-gynecologic cohorts, so typically breast and prostate cancer. And in fact, if you pull up the NCCN is the National Cancer Network, who publishes nationwide guidelines on, both cancer-directed therapies as well as supportive care and survivorship. Their guide has nearly 300 references, their bone health guide does, and none of their references are from a cohort of gynecologic patients, despite the fact that they are undergoing oophorectomy plus adjuvant therapy. There's varying recommendations. You guys can see, in this table here, the NCCN post guidelines, ASCO has guidelines. Typically people are touching on, women needing to be screened for osteoporosis at any age if they've, had induced early menopause, if they have undergone treatment that reduces sex steroids, if they, have had glucocorticoid therapy, in addition to other very well-known risk factors. But there's not really good guidelines as to how often these patients should be screened, when after cancer therapy should we start screening. And so there's a kind of wide variety in what clinical practice is being done. And then in the cancer world, when it comes to survivorship and surveillance, the big question is who is responsible? Who's responsible for bone health screening? Is it the primary oncologist? Is it the primary care doctors? And particularly in the state of Wisconsin for gynecologic cancer care, we see patients from, all over the state and a couple of other, regional areas, and the health systems are not connected. So oftentimes our patients have PCPs that are, throughout the state. And so there's not a great way to communicate those screening practices with them. And so, this notion of who's responsible and who's communicating, if we have a 40-year-old patient who's undergone an oophorectomy, chemotherapy, we know her bone health is important, but who's responsible for making sure that that screening is done? And like I mentioned, there's no gynecologic specific guidelines. So recognizing this lack of data, myself and some of my colleagues were invited to write a review paper looking at the current state of the literature. And there have been a couple of studies that have looked at disease-specific risk. And by disease-specific, what I mean by that is what type of gynecologic cancer. Not all gynecologic cancer is treated the same. And so there's been a couple of studies that have looked at differences in the type of gynecologic cancer and how that relates to bone health. So there was a study in 2015 by Lee and colleagues that was a retrospective case control of about 300 patients who had endometrial cancer and cervical cancer, and compared that to healthy controls. They compared available DEXA data. And what they found is that bone mineral density was significantly lower in patients with cervical cancer versus healthy controls. And you can see those L4 lumbar T-scores there. The incidence of osteoporosis was also higher in the cervical cancer patients versus healthy controls. And they did not find any differences in patients with endometrial cancer as compared to controls. Another similar study by a different author with the last name Lee about a year later also performed a retrospective case control of about, just over 100 patients with gynecologic malignancy compared to healthy controls. All of the patients in this cohort did undergo adjuvant therapy. And what they found is that there was significantly lower bone mineral density at 1 year in patients with gynecologic cancer versus their healthy comparisons. And the greatest decrease in bone mineral density in this study was found in endometrial cancer. When it comes to oophorectomy, interestingly, there have not been any studies that have independently investigated the effects of ovarian removal in a gynecologic oncology cohort. There certainly are studies that have looked at, ovarian removal for non-oncologic indications, and we are all very familiar with, both menopause and early oophorectomy and the effect on bone. There has been one study that looked at the impact of oophorectomy on bone mineral density in women with BRCA mutations. So women with BRCA mutations typically are recommended to have their ovaries out either by age 40 for BRCA1 or age 45 for BRCA2. So this is an entire cohort of women who are recommended to have oophorectomy prior to, what we consider natural age of menopause at about age 52. So this study was a retrospective review of about a little over 200 women. Mean age was 50. You can see a huge range here, 31 to 80. All had BRCA mutations, all underwent oophorectomy. And what they did was they investigated the rate of osteoporosis as detected by a DEXA scan. Of this cohort, 44% had had one DEXA at some point following their oophorectomy. And the median time between oophorectomy to bone loss in this group was 29 months. 56% were diagnosed with osteopenia, 12% with osteoporosis. In terms of other adjuvant therapies, so there have been a couple of studies that have looked at the effect of chemotherapy in gynecologic cancer patients. What's so interesting, particularly with regard to chemotherapy and bone health, is that there are just dozens and dozens and dozens of studies in breast oncology, and there's hardly any in gyn-oncology, despite the fact that all of these patients are undergoing oophorectomy plus adjuvant therapy. One of the first studies was done in 1997. This study measured bone mineral density before and after chemo in just a very, very small cohort of 15 women, very young women with a mean age of 38. These women all had ovarian cancer who underwent cytoreductive surgery with oophorectomy followed by platinum-based chemotherapy. And they compared that to controls who had had oophorectomy only, really looking to see what that chemotherapy effect was. And what they reported was that those receiving chemo did have a significant decreased percentage change in bone mineral density as compared to the controls being the oophorectomy only group. It was quite a few years before anyone else looked at this. And then in 2010, there was a publication in another small cohort of 40 patients with gynecologic malignancy. And they measured, CT measured bone mineral density over a 1-year period. And they saw significant bone loss in all patients, regardless of their adjuvant therapy. And then ovarian cancer patients who received chemo had the highest reduction in their bone mineral density of almost 16% at 12 months. Another adjuvant therapy that is used fairly often in gynecologic malignancy is radiation therapy. Interestingly, radiotherapy is the most studied area of bone health in gyn cancer patients. So there have been several studies that have associated radiotherapy with bone loss and pelvic insufficiency fractures. There was a recent review published that compiled the data of 38 studies. It was a little over 6,000 patients. And in that study, they reported a 9.4% insufficiency fracture rate in women undergoing pelvic radiotherapy. And this was measured anywhere from about 8 to 40 months after treatment. Probably one of the only prospective studies that has been performed in gynecologic cancer cohort was a study that was published in 2020. It was a prospective cohort of 239 patients with a median age of 51, all women with gynecologic malignancy that included cervical, endometrial, and vaginal, who had undergone pelvic radiotherapy from 2008 to 2015. They measured the incidence of pelvic fractures and changes in bone mineral density over time. They performed biomarkers and DEXA scans at baseline, 3 months, 1 and 2 years following pelvic radiotherapy. And what they reported was that the proportion of patients with osteopenia or osteoporosis had increased about 20% from baseline to 2 years. So at baseline was 50%, and by 2 years following radiotherapy, that group had increased to 70%. In that time frame, they also had 8% of patients diagnosed with fracture. And significant risk factors that they discussed were patients who had baseline osteoporosis, patients who had higher baseline bone-specific alk phos, and patients who were older at time of pelvic radiotherapy. Hormonal therapy. So women with gyn cancers are commonly treated with hormonal therapy. Interestingly, no studies have identified, or I have not yet to identify a study that has looked at the effect of hormonal therapy on bone health in a cohort of women with gynecologic malignancy. This again is so ironic because there are just dozens and dozens of studies investigating this exact question in breast cancer. And there are even some of the large phase 3 trials investigating the use of aromatase inhibitors for treatment of breast cancer have published on bone health data. And in those breast cancer cohorts, they have found significant bone loss and fracture risk in breast cancer patients taking AIs. But we do not have data on this exact same drug in a cohort of gynecologic cancer patients. So current recommendations. So as I mentioned, there are no current recommendations for bone health screening in gynecologic cancer survivors. So when myself and my co-authors wrote this review paper, we tried to really summarize the very limited evidence into some type of guideline for our gynecologic oncology colleagues to follow. And so, based on the best available evidence, we had recommended osteoporosis screening every 1 to 2 years for patients who are considered high risk and have a history of gynecologic malignancy. And we considered the high risk patients based on best available data to be premenopausal women who had undergone a bilateral oophorectomy plus or minus adjuvant therapy, women who have undergone pelvic radiotherapy regardless of their age, and women with an increased baseline risk for fracture. And the way that we defined that was anybody who who has any of those risk factors listed there, which are common risk factors for osteoporosis, as you are all familiar with. This work then led to a retrospective study that was performed with our group here at UW using opportunistic routine CT to identify bone loss in a cohort of gynecologic cancer patients. So this project, we performed a retrospective cohort study of patients with uterine and ovarian cancer who were less than age 65. We wanted to focus on women who were pre and kind of in the peri and early menopause. Uterine and ovarian cancer patients were chosen because they're the most likely to have numerous CT scans over time. And since we were doing CT measured trabecular attenuation measurements, we chose that particular group of patients so that we knew we would have the CT scans. All of these patients had undergone oophorectomy for gynecologic malignancy between 2010 and 2014. And we went back, pulled their CT scans and measured bone mineral density and categorized osteoporosis risk. And what we did was measured them at baseline 1, 3, and 5 years. And so you can see here, this is a pretty typical UW Cancer Center list of demographics. So our, predominantly white patients, BMI 31, age of diagnosis was 53. Like I said, mostly ovarian cancer patients with about 20% of our cohort as uterine. The majority of our patients were advanced stage, but we do have, about 30% of patients being early stage 1 and 2. You can see here, all patients underwent oophorectomy, about 83% had received chemo, about 17% were pelvic radiation. We did exclude patients that had undergone vaginal brachytherapy, which is just about a 5 millimeter depth radiation to the top of the vaginal cuff and is not really associated with bone loss. So we did exclude patients from that categorization. You can see a few other demographics of that group there as well. And here are our results. So pretty shocking to all of us. But when we compared the baseline and 1-year data, you can see here in our chart that Hounsfield units went from 179 to 146 in the first year after treatment. And remember, this is a cohort of patients with a mean age of 53. And if you are familiar with any of Perry Pickard's data, typically we would expect women who are postmenopausal to have a decrease in Hounsfield units of about 2 a year. And so these women are decreasing about 30 Hounsfield units in the first year. And then certainly it kind of continues. You don't see quite as dramatic of a drop in the 1, 3, and 5-year time frame, but that 1-year drop was pretty surprising to all of us. In terms of our multivariable analysis, we did find that pre-treatment bone mineral density was a predictor at all time points. That makes sense, and that's consistent with other studies. Chemotherapy predicted bone loss at 1 year, so patients who had chemotherapy were more likely to have bigger drops in their Hounsfield unit measurements at 1 year. And then current smokers were predictive of bone loss at 5 years. So the conclusions from this study were that, younger gynecologic cancer survivors experienced significant bone loss in the first year. Osteopenia and osteoporosis risk are increased in this population following treatment. And based on this, we really feel that bone mineral density assessment 1 year following treatment is probably warranted. I think people think of this as a longer survivor issue, but with some of the data that is emerging, it may be necessary that these women are, we're getting these women in for screening within that first year following their treatment. What this study also did was, showed that opportunistic CT is a really nice and feasible screening tool. Our patients are getting a lot of CT scans, and this is an excellent way to quickly screen. Future direction. So as Dr. Binkley mentioned, we are currently designing a protocol for a prospective cohort study investigating osteosarcopenia in women with gynecologic cancers. Our primary objective is going to be DEXA and fracture risk. We're measuring a handful of secondary objectives, including some functional and nutrition markers. This is currently funded by institutional funds as well as a American Cancer Society and UW-ICTR pilot grant. And I am partnered with Dr. Binkley and his team at the UW Osteoporosis Research Center. I think we're hoping to be open for accrual to this study this summer, so just in the next month or two, and we're really excited to finally get some good prospective data in this cohort of patients. I want to thank my whole mentor team. There are a lot of them, and they do wonderful, wonderful work for me and guide me in a path in which I have stumbled upon. And I am no osteoporosis expert, but I do recognize the importance that we keep our patients healthy once they've survived something like a gynecologic malignancy. And I would be happy to take any questions.
Janelle, thank you for going into a field that's in dire need of knowledge. I think Joe Shaker has a question, but as long as I've got the floor, I'm going to ask one as well. I'm struck that oncologists love zoledronate. I think there's good reasons for that. And are you aware of any data using ZOL in the setting of GYN malignancies?
No, so it is all over the breast cancer and bone health. There was one trial that looked at giving it, and it was a trial that never accrued. I found it in just clinicaltrials.gov, but they never accrued, never reported anything. And so no, but I have come across it a lot in the breast cancer literature.
Okay, thank you. Joe, do you want to ask your question?
Maybe part of our future, we'll see.
Sure. So do women, one of your first slides, you had women with cervical cancer having lower bone density, but not women with endometrial cancer. Women with endometrial cancer start off with a higher bone density? They have higher estrogen levels than their peers?
So typically, yeah, there's that study. I have so many questions for that study too. I wish they would have broken down a lot of different things. So I think in that particular one, the reason why, let me see if I can find it. So what they didn't talk about is that advanced cervical cancer patients almost always undergo pelvic radiotherapy. So and all endometrial cancer patients don't. So some do. This particular study did not break down the percentages of adjuvant radiotherapy in those groups, but I actually think the difference in these two subgroups is probably pelvic radiotherapy. In terms of estrogen, now estrogen is interesting because the biggest risk factor for a type 1 endometrial cancer, which is your most common estrogen positive cancer, is obesity. And we know that obesity raises, peripheral circulating levels of estrogen that then cause hyperplasia of that lining of the uterus that can lead to cancer. So I think your question is excellent. And I think whether these women have higher bone density because of that is a really interesting question. You've got my wheels turning. I don't know if we know that yet. But I certainly think that's something we could easily look at once I've got this prospective data. But for this study, I think the difference is the pelvic radiotherapy.
Thank you.
Okay. We have one last impossible question from Paul Anderson. Any suggestions on how to treat pelvic insufficiency fractures after radiotherapy?
Yeah, you guys might be able to teach me something. This is one of the absolute worst things that I admit to my service. I mean, these women are just in such an incredible amount of pain. And honestly, I feel like we consult ortho, we try to get people involved, and it's just, rest in pain medicine, and it's awful. So I would love to hear if any of you have an answer to Paul's question.
I certainly don't. Obviously, anabolic agents like the PTH are out of the question. But romosozumab, maybe there would be an indication for that. I don't know. Maybe we could ask one of our later speakers, Dr. Cates, who's a traumatologist, if he has any opinion on pelvic insufficiency fractures. I think most orthopedic surgeons, if you see radiation, we just throw our hands up and say, I don't really have a good idea here. I don't know, Steve, if you could comment.
Yeah, I don't have a solution to this either. It's a miserable problem. I don't know that fixing these results in a good outcome. It's some cases might be an option, but it's a miserable problem.
Yeah.
I think the answer may lie more in how do we prevent these from happening to begin with, probably more than treating them once they happen. But it's just awful. And a lot of these patients are cured. I mean, that's what, at the heart of this issue is you've got patients who have been through so much. So many of them have excellent prognosis, and then they just have, terrible morbidity related to many things, but, bone health being one of them. We certainly need to do better in gyn cancer. It's amazing to me how much has been done in this area in bone and prostate, and just nothing for our ladies. So.
Yeah,
Right.
I see the men, prostate cancer in men is the same problem that you're dealing with when I see these pelvic insufficiency fractures, sacral fractures. And unfortunately, most of the time it's significant delay in diagnosis because back pain is so ubiquitous that people don't think about this. They're hard to these fractures are hard to diagnose on plain x-rays. You almost need MRI scans. And so these people come by very late in their disease. Perhaps earlier in the disease, we could do some percutaneous fixation that, maybe it will help. I don't have any idea if it will or not, but at least it'd be something that could be done.
Okay, thank you, Janelle. In the interest of staying on time, I think I'll turn it over to you, Paul, to introduce our next speaker.